as your chair said, there's been widespread support, I think, for the concept and purpose of health and wellbeing boards. I think largely because people have ambitions for them because they fit well with place leadership. They're not necessarily reinforced by the things that were said about them in the bill or more broadly. But there are real issues and uncertainties, I think, about how governance is going to work across the system. People sitting around the table will have accountabilities, some of which are potentially quite strong, that are separate to the collective aim of the Health and Wellbeing Board. And some people will have a very local focus about doing the best thing for the place, and others will have that, but they'll also be part of a national system. And so the relationship with the National Commissioning Board, Public Health England, and the political relationship with the Council will all need to be tested. Districts are not going to have a statutory place on the Health and Wellbeing Boards. There was an attempt in the Lords to amend the legislation to make sure districts were represented, but it does make sense for them, clearly makes sense for districts to be represented in those areas where there is a county council, and it does present a challenge, particularly for public health, where most of the functions are actually at district level in a county scenario. I mean, the role of Health Watch is very unclear because it has a statutory place round the table of the Health and Wellbeing Board, so it is party to confidential decisions, wider discussions about the system, but is also the advocate of the patient outside and a commentator and judge of the system. I think that's an uncomfortable role. CHC's had it, I think, in the past, but it does need working through. The Director of Public Health is, in 70% of cases, already a joint appointment, but is employed by the PCT. They will switch their employment either by direct employment or by secondment in some cases to being accountable to the local authority, and that raises all sorts of issues and anxieties for them, but actually I think they'll be made welcome in local authorities. And there is at many places the use of external facilitators to hold the ring, at least in the short term. Further early indications are a lot of uncertainty about the burden that now seems to be placed on health and wellbeing boards to promote integration. This seems like quite a big ask locally and needs working through. And how to play providers into the equation is a big debate. In most places, health and wellbeing boards are keeping NHS providers out of the Health and Wellbeing Board formally in its shadow form, but sometimes third sector organisations, many instances third sector organisations are inside the tent. So how does that work out in practice? What is the relationship with providers? My personal take on this after years of joint planning is that there is a role for providers in needs assessment and in the development of strategies so that ideas can be shared about how best to respond to that, but they do need to be outside of any formal decisions about procurement or commissioning services. And then there's the additional complexity of children's services. Children's trusts were statutory and are no longer statutory. Health and wellbeing arrangements were optional and are now statutory. How does that work? And there's a real question mark about children's services, where I think typically there are 6 different strands of accountability to children's services to work through. If you think about the role of the National NHS Commissioning Board, the Council, and others sitting round the table. So the sort of final strands of my presentation are, what do we know from previous experiences about the principles of joint working, the principle of integration that could be relevant to making health and wellbeing boards work? Certainly from the point of view of the lessons of attempts to bring health and social care together since the war, and particularly since 1974, there is no single silver bullet that actually cracks this issue. It is fundamentally complex for the reasons I gave before about 2 parallel systems designed to be in parallel. And the Future Forum has said that one more time in their latest chapter on integration. And it's a mistake for people to search for that. It just doesn't exist. But you do need to get to the bottom of what it is you're trying to achieve, for which you think integration might be the answer. And I think we have stepped forward a bit in the recent debates about integration when we talk about the experience of the patient or service user being of an integrated service, so that they themselves have more of a sort of unified feel for that, and One expression of that is the single worker concept. Other expressions of that is the idea of a integrated health and social care personal budget, but it could also be organisations that are commissioned by health and social care to provide that wraparound service. You've got to kind of work out what's the question. Is it integration along the care pathway? Is it integration around making sure that people aren't in the wrong place in the health and social care system? Or is it more broadly integration with what the council's trying to achieve for people, housing, leisure and other things? And the answer may be different for different types of service or different types of patient or service users. And it's certainly highly relevant to carers. The third principle is to get a proper balance between the means and the ends. And we've had an undue focus historically on structural answers to integration, of which I suppose care trusts were the most obvious recent example from Alan Milburn, some of which have worked really well and continue to operate, some of which haven't. And I think the key message on this is working out both at a whole population level, but also at a service level, what it is you're trying to achieve. What's the end of bringing these services more closely together? And linked to that, there's the need to have what I describe as multi-level integration because what organisations do it operates at different levels, and some of the most successful integration is actually where the integration has been very much at the front line through joint teams, through shared roles, sometimes through new types of worker, but also through basic things like co-location or single points of access, those sorts of issues. One of the key things that I think health and wellbeing boards have got to sort out in their minds is the distinction between population accountability, improving outcomes for the population as a whole, which is very much the public health focus that will be brought to them, and service accountability. And people sitting around the table will come together largely, I hope, to improve outcomes for the population as a whole in that place, but they'll have in the back of their minds their service accountability, the things they've got to do. The trick is to connect the service accountability to the population priority so that people are doing what they've got to do for the service to achieve their bit of the population goal, rather than feeling that actually their loyalty is somewhere else and they're just going through the motions on working together. There's a great phrase, everybody uses it in presentations on this sort of thing, which is that partnership work is the suspension of mutual loathing in pursuit of external funding. And you know, one of the things that the sort of means and ends debate has been, I know, let's just give some joint funding and get people to force people to work together in order to use that funding. And there is a very big risk that health and wellbeing boards will just be about the public health money, or just be about the money transferred from the health service to adult social care for reablement, for example, because it's easy to focus on that.